have a quick go through to the liver. Liver is divided into 8 segments by the quinine, known as the quinine segments, by the IVC. IVC is middle hepatic vein, left right hepatic vein, and the portal vein. And then you have a classification which is known as the modified Child-Pugh score, which is based on BAPE, that is bilirubin albumin ascites and prothrombin encephalopathy. Bilirubin 1 to 2 is normal, more than 3.1 is 3. Albumin more than 3.5, 2.7. Prothrombin time 1 to 4 is 1, more than 6 is 3. Or it can be INR more than 1.2.2 and less than 1.7. No encephalopathy is 1 encephalopathy for mild, and then there's going to be 3 or 4 episodes of encephalopathy, then you will give a score of 3. If it is if the total score is 5 to 6 is Child-Pugh grade A, B and C. So 5 to 6 is A, less than 10 is B, then 10 to 15 is C. Then you have a MELD score. MELD score is the criteria which was used to predict the mortality after TIPS previously, but right now we use MELD score to assess to liver transplant, to assess liver transplant. Okay, waiting list. So there are 3 things that is included. That's creatinine, bilirubin, INR. Now there is a revised MELD for which sodium is also added. Remember, Mammootty CBI. Creatinine, bilirubin, INR and sodium is also added to MELD score. MELD score is not used in amyloid, hepatocellular carcinoma and liver cancers. Now there is another criteria which is applied for liver transplant, that is known as the Milan's criteria. That is a single lesion less than 5 cm, 3 lesions where each of which is less than 3 cm and no other is spread. If these 3 are satisfied, then we can go with transplant. That is known as the Milan's criteria. And then there is a King's College criteria for the selection of liver transplant in case of acute liver failure. So if the acute liver failure is because of paracetamol and non-paracetamol, if it is because of paracetamol, you have to see if the pH is less than 7.3. That plus 3, more than 3 criteria here. If it is a non-paracetamol, you have to see INR. Okay, non-INR more than 6.5 means, or if the PT is more than 100 second means. That's the first thing. Now the other 3 criteria in paracetamol poisoning, the other 3 criteria is, one is INR will come, the other one is creatinine more than 3.5 and INR more than 6.5, grade 3 or 4 encephalopathy, plus hyperlactinemia and hyperphosphatemia. So this thing is coming means then you can transplant the patient. Okay, 3 or more. So it is pH less than 7.3 plus 3 of these criteria. The 3 criteria is ISG, ICG. What is ICG? That is 1 is INR, 2 is creatinine, grade 3 or 4 encephalopathy, hyperlactinemia and hyperphosphatemia. Then next is non-paracetamol poisoning, INR more than 6.5 and 3 or more of these 5 criteria. What are these 5 criteria? Less than 10, more than 50, non-A, non-B hepatitis, 7 days of jaundice before encephalopathy. 7 days of jaundice before encephalopathy, as in we are going to rule out an acute case like paracetamol toxicity. Then PT more than 18. If 3 or more of this is present, then we can go ahead with transplantation. Now if there is a case of acute variceal bleeding, how do you manage it? If there is an acute variceal bleeding, the first thing is you have to stabilize the patient, give terlipressin, octreotide IV fluid. Then the next thing that you do is endoscopy. Endoscopy, if it is an esophageal thing, you go for banding or sclerotherapy. Banding is preferred. If it is a stomach thing, then you would go for cryoacrylate glue. That is, you put a glue. And then if still that there is bleeding, use balloon tamponade, which is using Sans taken back Blackmore tube, where you inflate the gastric balloon with 300 ml of air and you inflate the esophageal balloon with 40 to 60 ml of air. That is balloon tamponade. And then if still it bleeds, repeat sclerotherapy. So 2 times you are attempting sclerotherapy with Blackmore tube in the middle, and then you do TIPS. If still, with the help of an interventional radiologist, if still doesn't work, then you have to go for a shunt surgery. Now there is few shunt surgeries that we need to know. So first is space, but still, if you are doing TIPS is something that you do with right hepatic vein and portal vein. This is TIPS. What is the side effect of TIPS is it can lead to hepatic encephalopathy, which is the most common thing. Now there can be an immediate complication, which is nothing but a lot of blood would go from the right hepatic vein to the portal vein, and there can be capsular rupture. And then there can be shunt thrombosis in the long term. To connect this, that is to connect the two veins, that is the portal vein and right branch of hepatic vein, use PET polytetrafluoroethylene. Now there are two types of shunts. One is selective shunt and the other one is non-selective shunt. What is non-selective shunt? Non-selective shunt means it is in which the entire portal blood is diverted into systemic circulation, where the patient will develop encephalopathy. Selective shunt means only the splenic vessel is diverted, so that the patient's risk of encephalopathy is nil. Okay, but ascites will be formed. That's all. Okay. So what is the example of non-selective shunt? Linton shunt. Linton shunt, what you do is you will take the splenic vein and you will connect it to the, this is page number 303. Okay, page number 303 of the main notes. Linton shunt is a non-selective shunt. Now two selective shunt, that is Warren and Inoguchi shunt. Okay, Linton is splenic vein to the renal vein. Splenic vein to renal is Linton. Linton is LSR. Splenic to renal is Linton. And you have to do Linton. You have to cut the spleen out. You have to do splenectomy. So Linton is splenic vein to renal vein, and you have to cut the spleen. This is a non-selective vagotomy and non-selective shunt. And then you have two selective shunts. What are the two selective shunts? One is Warren shunt and the other one is Inoguchi shunt. So what is Warren shunt? Warren shunt, you are not doing any splenectomy. You are connecting the splenic vein to the renal vein. You are removing the distal proximal part of this formation of the portal vein. The proximal part, you are just taking this out. You are connecting this part to the renal vein. That's what you are doing. This is known as Warren shunt. So Warren shunt means you do a war to save the spleen. Now Inoguchi shunt, all this Inoguchi, ivory, all this usually in surgery it's something related to stomach. So Inoguchi shunt, I will take the left gastric vein and I will connect it to the IVC instead. Okay, Inoguchi to IVC. Inoguchi, something to deal with stomach, and you connect it to IVC instead. And then you're having Saguaro operation. Saguaro operation means I'll first devascularize the entire stomach and the OG junction. I will transect the part of esophagus which is causing the bleed, and then I will remove the spleen. I will do truncal vagotomy and pyloroplasty. Now instead of truncal vagotomy, if I'm doing high selective vagotomy, and if I'm not doing pyloroplasty, it will become modified Saguaro operation. Now you have BCLC staging of the carcinoma of the liver. Alright, so that's one more thing that we need to know. So how do we understand that there is a very early, intermediate, advanced and terminal? If you see child's puke score C, then you don't have to do anything. You have to do only palliative treatment. C, palliative. If there is any portal vein invasion or extrahepatic spread, or if you see that the PS is 1 to 2, then you have to give sorafenib. Sorafenib is serine threonine inhibitor, VEGF inhibitor, tyrosine kinase, and PDGF inhibitor. VEGF, tyrosine kinase, PDGF, serine threonine. Portal vein invasion or extrahepatic spread or PS 1 to 2, sorafenib. Alright. If you see multiple lesion and PS is 0, there is no extrahepatic spread, you have to do transarterial chemoembolization TACE. If the lesions are less than 3 in number, less than or equal to 3 centimeter, or if they are less than 2 centimeter and single, in such cases you have to do transplant. And just do MELT score. If it satisfies, do transplant. If it is single, try to use ethanol and acetic acid. Mostly if it doesn't work, go for transplant. One word answer, transplant. So in simple terms, if it is C, do palliative. If there is portal vein extrahepatic spread or PS 1 to 2, sorafenib. All the other cases, PS is 0. Multiple TACE. Less than 3 centimeter, less than 3 anything, transplant. Less than 2 centimeter, transplant. Everything else is transplant. So that's all. After that, we'll see about portal hypertension. There are two types of portal hypertension. It can be non-cirrhotic portal fibrosis or extrahepatic portal vein obstruction. An example of extrahepatic portal vein obstruction would be Budd-Chiari syndrome. Budd-Chiari syndrome, the important thing is there will be chordate lobe hypertrophy in CT scan. So when you're doing a CT scan and you see chordate lobe hypertrophy, you have only one DD in your mind, that is nothing but Budd-Chiari syndrome. When the liver is normal in Budd-Chiari syndrome, you can do a portocaval shunt and you will not have any encephalopathy or ascites, but it can very soon lead to cirrhosis and liver transplant. In Indian setting, it is mostly because of IVC web. Otherwise, it's usually in Western setting, it is because of hepatoid vein thrombosis. And then when you're doing a Linton shunt in someone who has a normal liver, then you will not have hepatic encephalopathy. Now, there's another shunt which is known as a Rex shunt. So Linton shunt is something that, it's proximal splenic vein and splenic vein to the right renal vein, and there is splenectomy involved. But there is something called the Rex shunt. Rex shunt is the most physiological shunt, which is superior mesenteric vein to the left portal vein. This is Rex shunt, the most physiological shunt. And then there is pyogenic liver abscess. In pyogenic liver abscess, the liver enzymes will be elevated. In amoebic liver abscess, the liver enzymes will be normal. In amoebic liver abscess, you will give metronidazole TDS, 750 mg for 2 weeks. Okay. Now, if there is no resolution, no response for beyond 3 days, your diagnosis you're not sure, it's superficially located in the left lobe, and if it is more than 5 centimeter or that is more than 75 ml, such cases you will do aspiration. Otherwise, stick to metronidazole 750 TDS 2 weeks. And in addition to that, you can give other amebicides like diloxanide, emectine, okay, into 10 days. So that's how you deal with it. Now we're having a hydatid cyst. Hydatid cyst will have ectocyst, laminated membrane, and you're having a germinal layer. Okay, germinal layer is a living layer, laminated membrane, and ectocyst. Now there is Garvey classification of hydatid cyst, which was old. Now we're having a WHO classification where you have CE 1, 2, 3, 4, and 5. CE 1 is hydatid stand. CE 1, 2, 3 is living. Remember, we 3 are living children. Alright. Hydatid stand. Honeycomb is 2. Water lily is 3. 4 is bag of wool. 5 is calcified. So that's the Garvey classification. Hydatid cyst is treated with albendazole for 2 weeks. Okay, so remember 2 things. One is amoebic liver abscess is treated with metronidazole, TDS 750 mg into 2 weeks, and this is for amoebic liver abscess. For hydatid cyst, you are treating it with tab albendazole. Okay, albendazole into 2 weeks, and then after which you will plan for surgery like PER. Okay, PER, for which you use 20% hypertonic saline. So 1, 2, 3 is living cyst, but PER is only done in a living cyst. Even in living cyst, you will not do it in a honeycomb. Honeycomb is 2. Dead cyst you will not do. Biliary communication you will not do. If it is superficially located, you will not do. If the lung hydatids, also you don't do this PER, because lung hydatids, they don't have a pericyst. So when you do PER in the lung hydatids, it will just rupture. Tumors of the liver, there are few things that you need to know about the tumors of liver. You need to know about hemangioma, FNH, and liver cell adenoma, and fibrolamellar HCC. FNH and fibrolamellar HCC, they both have a central scar. But how do you differentiate them? Fibrolamellar is neurotensin B positive and there is no cirrhosis, and it is also having AFP normal. But if they say there is a use of OCP, there is risk of host rupture, hemorrhage, it is benign, all of these things, it is probably FNH. So OCP is associated with FNH. Fibrolamellar, it is associated with neurotensin B. Hemangioma, it will have light bulb appearance and T2-weighted MRI, slow contrast enhancement, and there is a risk of rupture. And next is liver cell adenoma, is mostly seen in young women, maybe 20 to 40 years. Here also there is risk of use of OCP and steroids. So whenever they say OCP and steroids followed by lung mass, it is FNH or liver cell adenoma. If they say central scar along with it, it is FNH. Otherwise, it is liver cell adenoma. Liver cell adenoma is associated with beta-catenin mutation and there is risk of malignancy and rupture. So hemangioma, do you treat? No, you don't. For FNH, do you treat? No, you don't treat. But liver cell adenoma, there is a risk of cancer, so you treat. And how do you treat? You do surgery. So again, when they say OCPUs, two things should come into your mind. One is FNH and liver cell adenoma. When they say single 20 to 40-year-old women, OCP, steroids and all that, and there is risk of cancer, it is liver cell adenoma. When they say central scar, it is FNH. Another central scar is fibrolamellar HCC. It is associated with neurotensin B. Slow conquest enhancement and light bulb is hemangioma. Paraneoplastic syndrome of liver cancer is hypercholesterolemia and hypoglycemia, hypercalcemia, polycythemia. So what all are increased? RBC, calcium, cholesterol is increased. Glucose is reduced. This much you need to know. Now the genes or tumor markers is glypican, PIFKA, AFP-L3. These are all the markers of malignant tumor. And here you will see early contrast enhancement in the arterial phase and rapid washout. So early enhancement and rapid washout means it is liver cancer. Slow enhancement light bulb is hemangioma. Central scar is fibrolamellar and FNH. And then associated with malignancy, benign which can become malignant is liver cell adenoma.